Hi there, so I think we'll go ahead and get started today. My name is Jenna Hemmerich. I'm a palliative care nurse consultant in Prince George. Just a reminder, please to mute your mics. And this session will be recorded today. And then if you can, please fill out the evaluation and send it to Sandra Schmaltz at the end of the presentation. If you can, please. Thank you. So today's presentation is on malignant wounds and palliative care. So today the objectives are to define what the malignant wounds are, discuss assessments required for the wounds, discuss common symptoms, discuss wound and symptom management, and then discuss treatment of the malignant wounds. Palliative care is focused on holistically supporting the individual for comfort rather than for cure or healing of a wound, while improving the quality of life and dying for those who are at or near end of life. So although the usual goal and plan of care is directed towards healing a wound, for individuals at the end of life with non-healing wounds, palliative care, wound care, may be the desired and most appropriate goal. So malignant wounds occur when cancerous cells invade the epithelium, infiltrate the supporting blood and lymph vessels, and penetrate the epidermis, resulting in a loss of vascularity, leading to tissue death and necrosis. So a malignant wound can develop in one of three ways: a primary skin tumor. So a squamous cell is abnormal cells arising in the squamous cells, which compose most of the skin's upper layers. The basal cell, so these line the deepest layers of the epidermis, or the outermost layer. And then the malignant melanoma. This is less common but highly dangerous form of skin cancer. So when found at an early stage, melanoma has one of the highest cure rates of all cancers at more than 90%. But if left untreated, melanoma starts to invade the skin. When it reaches the bloodstream or the lymphatic system, it has a chance to spread to the other parts of the body and cause death. Soft tissue, including muscle fat, blood vessels, nerves, tendons, and the lining of your joints. So another way is as a result of direct invasion or infiltration of underlying primary or recurring tumor, so breast or soft tissue sarcoma. And the third is a metastatic spread from a distant tumor. So these wounds can progress in a variety of forms, including ulcer, cavity, nodules, tumor mass erupting directly from the skin. And the tumor is considered fungating or malignant once the cancerous cells penetrate the skin through the process of ulceration and proliferation. Wounds in end-of-life patients are often chronic in nature, as healing is significantly impaired due to physical condition and existing comorbidities, which we'll get into in a little bit. So the incidence of malignant wounds is 9% across all cancers, occurring mostly in the breast, 62%, and head and neck at 24%. And the incidence also goes up in the elderly. So as I mentioned, they rarely heal and they'll continue to grow and evolve. So assessing palliative wound care focuses on controlling pain, choosing appropriate dressings, managing infection, and protecting the peri-wound area. It is essential to perform a head-to-toe assessment of the end-of-life patient, including physical and psychosocial health and all-over quality of life. I mentioned the psychosocial pact. These malignant wounds can have quite a effect. They produce fear and anxiety, depression, denial, anger, guilt, a loss of control. There's aspect of embarrassment and social isolation, and lowered self-esteem. So assessment of malignant wounds is similar to that of the pressure sores, but there's not an analogous system for supporting the kind of a standard assessment and classification. So important parameters to record include the wound history, physical parameters, conditions of proximate wound tissues, presence of necrotic slough or exudate, infectious status, pain assessment, odor and bleeding, and like I mentioned, the psychosocial impact. We also need to be assessing if these lesions are near an airway for a potential for obstruction. Is the lesion near a major blood vessel? So do we have a potential for hemorrhage or vessel compression obstruction? So to get more into the comorbid health problems, so we want to take note if the patient has diabetes or peripheral vascular disease, if they're immunosuppressed, have anemia, if there's tobacco use history or heart disease. We also need to do a complete med review, so medications the patient is taking. Are they on any coagulation therapies, NSAIDs, steroids, or chemotherapy? Their nutritional status. So this is a poor nutritional status is really common finding in patients with cancer, and impairs the ability to maintain skin integrity and heal wounds. So adequate nutrition is essential for healing and plays a pivotal role in the success or failure of the treatment plan. So we're just wanting to assess for how is the appetite, is there recent weight loss, is the patient having swallowing difficulties or nausea and vomiting. So we just need to do a complete assessment there as well. So diagnostic tests and psychosocial implications, like I mentioned. Also, we want to assess the patient and family goals. What are their goals of care now? What would they like to see in the future? And we need to constantly be reassessing those. And then past and current treatments for cancer. So have they had surgery, radiation, chemotherapy? And we want to know any allergies to dressings and to drugs. And then also physical capabilities and functional limitations. So we need to know if they have difficulty walking, blindness, deafness, anything that could make. And the palliative performance scale is also good to take note, so we kind of all know where this patient is at on the trajectory. So goals of care. The goals of care for malignant wounds may shift from healing to a palliative approach, focusing on 3 core principles. So symptom management, wound management, and then treatment of the underlying tumor, if possible and appropriate. Symptoms of malignant wounds. So at end of life, wound care focuses on pain management, odor and infection, management of exudates, bleeding control, and then I mentioned again, self-image, dignity, quality of life. So we need to be focused on this with our patients. So main concerns is the pain, odor, and the drainage arising from the infection or from the malignant wound, and this can cause most distressing to the individual and therefore should be treated. This can also be quite distressing for family members involved in the care of their family member. So managing symptoms, starting with pain. Pain is anything the patient says it is. The majority of patients with a malignant wound experience moderate to severe pain, especially during dressing changes. Wound pain can be caused by tumor pressing on the nerves or blood vessels or by exposure of the dermis. And pre-medicating the patient with a pain medication 20 to 30 minutes before changing the dressing is an important part of palliative wound care management. And this can be very patient-specific. So before every dressing change, we just need to be assessing what worked in the past for the patient, how was their last dressing change, what did they use, and how can we better their care. So just a constant reassessing. So the pain also can be a result of many causes, including emotional factors, but it generally is a mixed etiology, so we just need to be doing those thorough assessments. So we need to select a dressing that can remain in place for several days, although this is not always possible when there's a large amount of exudate. So dressing selection is very important. We want to protect the peri-wound skin, and we want to use non-adherent dressings. And I'm going to speak more to protecting the peri-wound skin and pruritus and appropriate dressings later in the presentation when I discuss managing exudate. So we want to use minimal mechanical force when we're cleansing these wounds. Use warmed products such as saline or gauze pads, and we want to avoid using antiseptic. So there's a DST on wound bed preparation, and that's a great one to help you choose your appropriate dressings. So management of pain requires appropriate analgesia as well. So malignant wound pain may be caused by stimulation of nerve endings, so nociceptive pain, and or pain caused by nerve dysfunction, so that would be the neuropathic pain. So we may need to be using non-opioid and opioid for pain management for nociceptive, and we may need to add a gabapentin or an amitriptyline to help that neuropathic pain. So pain needs to be continually reassessed, so we can use the ESAS or the Edmonton Symptom Assessment Scale, or a 0 to 10 scale, or the FACES scale if that's more appropriate for your patients. So pain may only be present during dressing changes, but pain may also be present at all times for our patients, so just that thorough assessment. We can also use some topical opiates, some analgesic creams or gels or morphine or hydromorph spray. They can be helpful in managing our patient's pain. So it'll be very patient specific, but we can definitely help our patients during the dressing changes. And for odor control, so tissue deprived of oxygen and nutrients becomes devitalized and non-viable, and bacteria thrive on this moist, devitalized tissue. So as bacteria colonize, necrotic material appears in the wound and creates odor, which varies depending on the bacteria present. Anaerobic bacteria are usually present in the necrotic material, and they thrive in the absence of oxygen and become deeply buried within the wound. Anaerobic bacteria also have a stronger, more offensive odor, and that can be particularly distressing to the patient and to their families. And the wound odor can be embarrassing to the individual and lead to isolation and poor quality of life. Therefore, it's vital that we try to improve this for our patients to help their quality of life. So treatment is aimed at removing the cause whenever we can, or the odor itself. Saturated dressings can hold odor, so changing these dressings more frequently can help. Irrigate frequently also helps remove the exudate and odor. If the patient is able to shower, they may want to be able to let the wound kind of rinse off in the shower, just with a gentle irrigation. And the non-friable tissue can be debrided, and autolytic debridement is often the least painful for the individual, with sharp debridement being really the last resort to prevent excess pain and bleeding. So metronidazole can be used successfully to control odor, and it's available either in oral or topical preparations, and are very effective in reducing anaerobic bacteria found in the deep wound or superficially spreading tumors. So the topical gel can be applied 1 to 2 times a day across the entire surface of the wound, but frequent application can also lead to product buildup. So we just need to be thoroughly cleansing these wounds. Alternatively, the dressings can be soaked with the fluid and laid over the open surface to control odor while maintaining a moist wound environment. We just have to be careful with this if we're creating watching the peri-wound skin, I guess, for maceration. And this also can be used in higher doses if odor is not controlled, but side effects may occur such as nausea, so our thorough assessment there. We also can use activated charcoal dressings, and they're effective in controlling odor quickly. The dressings work to attract and bind the volatile odor released by the anaerobic bacteria, and they're available for either a direct wound application or to provide a top layer in a combination dressing, but generally work best if completely sealed at the skin's edge. And then the silver impregnated dressings are also effective for treating infections and in controlling odor. So sugar paste and honey can be used for their antibacterial and debriding properties. The high sugar content produces a hyperosmotic wound environment to inhibit bacterial growth and assist in debridement. And so we also can use room deodorizers, ventilation fans. People have used a tray of kitty litter in the past, kind of tucked under the bed, to help grab some of those odors out of the air. So odor control is vital for enhancing quality of life for palliative care patients receiving wound care. So as nurses, we're doing these dressings, and we're there for a very short time, but our patients are living with this smell 24/7. So it can be a very big deal for our patients, and we really need to address their concerns. So the exudate is the inflammatory fluid that seeps from the extracellular spaces in what is known as exudate. All bacteria produce exudate, and the color and odor of which vary according to the causative organ. And then managing them can present a major challenge. So for example, the green exudate we can see generally indicates a gram-negative aerobic bacteria, which responds really well to silver found in many of the dressings. And the more persistent the inflammation or infection is, the more exudate that will be produced. So this can be sometimes caustic, and it can exacerbate skin damage by causing maceration, breakdown, and itching. So dressings that appropriately control exudate without necessarily increasing wetness or dryness are recommended, such as an alginate, a hydrofiber, a foam, or a non-adherent dressing, often with a secondary absorbent pad. So again, I'm going to reference the DST for the wound bed preparation. And that DST number, if anyone needs it, is 1284160G. And it will just help choose your dressings and indications. So if drainage cannot be contained with dressings, we can consider layering or pouching. And then we also can consider a ET nurse to have a consult and be able to help us manage these wounds. So regular assessments for local and systemic infection are really important, as this can increase the amount of exudate and odor and break down the peri-wound skin further. So changing dressings when they become saturated is important, as overly saturated dressings can cause the wound bed pain and irrigate the peri-wound skin. Alternatively, if exudate is minimal, a low absorbency dressing such as a hydrocolloid or a semi-permeable film is recommended. So some of the hydrocolloids can be such as the Duoderm, Restore Plus, or Tegasorb, or Thin Restore. So these are not to be used in infected wounds, and like I mentioned, or in heavily exudating wounds. And these can be left on for 3 to 7 days. And hypergranulation can occur, and peri-wound maceration is something to assess for, so we just have to keep that in the back of our minds. So for antimicrobials, these are such dressings as Iodosorb, Actisorb, or Acticoat, and these are good for hydrating wounds, highly infected or highly colonized. Dressings contain antibacterial metals such as an iodine or a silver, and they can be used in combination with an alginate or a hydrofiber to just help increase the absorption. And activated charcoal can help also with this wound to control the odor. So absorbent dressings such as an alginate, a hydrofiber, so these are Aquacel silvers. There's other foams such as Restore or a leave-in. These can be left up to 7 days, and they hold 8 to 20 times their own weight. So these will help fill the wound cavity and obliterate the dead spaces. And then we also have the hydrogels, so Intrasite Gel, Restore, Hydrogel, or Duoderm. So these are non-adherent, so they prevent bleeding and the pain. They're moderately absorption and available in gels or in solid sheets, and they also can be embedded in gauze. So these are typically left 1 to 3 days, depending on the amount of exudate. So we just want to monitor for overhydration or peri-wound skin maceration, and we may need to use the protectant around the peri-wound skin. So Catherine Leask is an educator in home and community care in Prince George, and she sent me a website, which is www.clwk.ca. And this is, if you click on the Band-Aid, and then you can click on the Knowledge Library documents, and then there's a folder, Product Information Sheets. So this is the list that has pretty much all of the products that Northern Health carries as far as advanced wound care products. So this is a good resource for what we can supply to our patients for those advanced wound products. So exudate frequently contains proteins. So when combined with inadequate oral intake of protein, commonly seen as in an individual at end of life, the degree of hypoproteinemia, it can increase. So that's a condition where there is an abnormally low level of protein in the blood. And there are several causes, and all result in edema. So once serum levels fall below a certain threshold. So managing exudates can present a major challenge. So bleeding in malignant wounds. Malignant lesions are friable and predisposed to bleeding. Hemorrhage due to erosion of blood vessels is the most common emergency seen with malignant wounds and can also be related to decreased platelet function within the tumor. So these are such tumors as an ENT, so a carotid artery erosion from a neck metastases, or an oropharyngeal tumor erosion in the mouth, or tumor erosion into any adjacent vessels. So education is needed for the patient and their families to prepare the family and the patient as much as possible ahead of time. So advanced care planning is necessary for all these patients with the potential to bleed, as a symptom is a source of considerable distress. So at this point, we would want to consider stopping medications that would cause bleeding, such as warfarin, heparins, NSAIDs, ASA. And we also can refer to the Northern Health Hospice Palliative Care Symptom Guidelines on exsanguination. So it's a good resource. So blood vessels can become eroded from tumor cells themselves or secondary to necrosis or sloughing of tissues after radiotherapy. So to minimize bleeding, use a non-adherent or soft silicone dressing, maintain a moist wound bed, and gently clean the wound. And I mentioned, but dry dressings should be avoided. But if dressings do adhere, as they do sometimes, we can carefully soak them off with saline. And if bleeding does happen, we can apply direct pressure for 10 to 15 minutes. So prevention is always the best therapy. So the goal of palliative care is to optimize quality of life through the control of physical symptoms and attention to individual psychosocial needs. And palliative care and malignant wounds should focus on dimensions of treatment and care that include psychosocial components, including hope, meaning, and self-esteem. So we want to be optimizing our patient and family autonomy. So even with such things as enhancing their mobility and activity, providing equipment to help their quality of life, we want to help maximize their nutrition and provide home services as required. So this could be for home support to be in to help with bathing, to help assist with comfort and even changing their clothes if they're requiring help, if that's become difficult. And we want to involve the patient and family in care decisions and have open and honest communication with their goals and decisions. As goals of care are made, they can frequently change. Someone may decide to stay at home and manage their symptoms at home and their dressings, and this may become too much for the family and friends. So family and patient and friends looking after this patient, so they may decide then to go into hospice care or to go to hospital to have their more full-time care. So just always reassessing goals of care with our patients is very important. So treatment of malignant wounds. So the goals of the treatment will depend on the stage of the disease, the palliative performance scale rating, and the patient's priorities. So active disease modifying therapies may be aimed at resolving the lesions, but at some point this is no longer possible, as I did mention. And symptom modifying therapies should focus on odor control, effluent, infection, and bleeding and pain. So disease modifying therapy. So radiation, chemotherapy, surgery can all assist in controlling the malignant wounds by treating the underlying malignancy. Radiotherapy is the most common oncologic treatment and can be helpful in reducing tumor size associated with associated exudate, bleeding, and the pain. So radiotherapy will destroy malignant tumor cells, therefore reducing the size of the wound and alleviating symptoms. The surgery can be used occasionally to reduce tumor mass or debride the wound to extend a symptom-free period and to improve cosmetic appearance, but it may not be possible due to the extent of disease. health status, healing ability, hemorrhage, and or involvement of surrounding structures and organs. So every patient is an individual case with what treatments they would be able to receive, and if we're just able to provide comfort measures. So I just want to say thank you to the ostomy department at Prince George Hospital here. Danny was able to give me a lot of great resources to assist in the presentation, and so they are a great resource. I know through home care nursing they are able to get quite a bit of referrals and help through Pixelair by taking pictures and having them assessed by the ET nurses if needed. So there are resources out there available to us to help with assisting our patients in the community. So while cure is not always realistic, it's possible to provide compassionate and symptom-relieving treatment for palliative care patients who have malignant wounds. So this includes balancing the management of local wound symptoms such as odor, pain, exudate, and bleeding, while preserving the patient's dignity, self-esteem, and to maximize their quality of life. I just want to make note of a couple more resources that were really important. There is a DST on malignant wounds, and this number is 1284220G. And this, there's an algorithm, so for malignant wounds, assessment, management, and treatment. And it's quite a thorough DST that you can find on Northern Health website. And another great resource has been the BC Cancer Agency Symptom Management Guidelines in Care of Malignant Wounds. It also goes through factors for considering when managing malignant wounds. It goes through a focus assessment, so using ROPQRST V assessment. And then, so it just assists us in not forgetting anything when we're doing our thorough assessments. It will go through the types of wounds and how much exudate and their dressing choices as well. And it goes through symptom management and then resources and referrals at the end. So it's a great tool that can help in assisting treating these malignant wounds.